Well, good morning, everyone, and welcome to our Cardiology Grand Rounds. We have a special Grand Rounds today with a wonderful speaker that really does not need an introduction. She's truly a leader in preventive cardiology and women in cardiology, Dr. Erin Michos. Erin is Associate Professor of Medicine and Epidemiology at Johns Hopkins. She is the Associate also Director of the Preventive Cardiology Program, the Cicerone Center for Prevention of Heart Disease, and is truly, in my opinion, probably the preeminent center for prevention in the country with Dr. Blumenthal. She's associate faculty also at the Welch Center for Prevention and Epidemiology, and she has a joint appointment with the Bloomberg Epidemiology School of Public Health. She did her medical school at Northwestern, but loved Johns Hopkins and Baltimore for so many years. This is where she did her cardiology fellowship training, her prevention training, her Masters of Public Health, and has been on board there in their prevention center since then. A pleasure to have you here, Dr. Michos, and her interest is pretty much all the gamut of preventive cardiology. Women in cardiology. If you want to know about vitamins and vitamin D, she is the expert, and she's going to straighten your thoughts as to where you need to be and whether you need to purchase or quit the habit one way or another. And obviously an expert in lipids and all management and wellness and how to hopefully modify behaviors towards more wellness. She's an avid runner. She runs every day. I don't know how many marathons she's done, but certainly more than 30. So she practices what she preaches. And it really is an amazing feast of combining academe with ways of life to keep us healthy and all the research that she's done in the field. She's quite involved in many of the national trials that we all know about. Aortic, which is also very important here in Houston, Texas, with Christy Ballantyne, the MESA study, the new STURDY trial, and she's co-authored more than 200 publications in the field, really a leader in the field of prevention. And she also does, I did not know about that, a monthly article for the U.S. News and World Report about health section for the public audience, and I think really wonderful. So Erin, it's great to have you today, and welcome to Houston.
Thank you for having me. It's really a pleasure to be here at a place where there's so many people that I've admired from afar and got to meet in person, and so I'm grateful for your hospitality. So I can talk about a lot of different things about prevention, but today I'm actually going to talk about vitamins, minerals, and supplements, and is there a role in cardiovascular disease prevention? So I'll give you the Cliff Note version, which is probably not for most people. There may be a few exceptions, but hopefully you'll stick around for the longer version of that. So, what is a supplement? So it was defined by Congress in 1994 as any dietary supplement that can supplement diet that includes a whole host of things. Under this umbrella is vitamins, minerals, herbs, botanicals, amino acids, enzymes. But importantly, it falls under the umbrella of foods, not drugs, which means that it's not required that the FDA proves that it's safe before it goes on the market. Now, there is some post-marketing surveillance, and the FDA has removed products that have been shown to have harm and contaminants, but then it's sort of kind of cleaning up. They're not approved to be safe before they're on the market. And although they're not intended to be marketed as to treat, to diagnose, to cure, alleviate disease, a lot of times they're misinterpreted either deliberately or unintentionally for that purpose, and that's not supposed to be the purpose of supplements. And the reason why I keep having this talk is that supplement use is just so prevalent. It's estimated through multiple surveys that more than half of the U.S. population takes some kind of supplement. And I won't ask you to raise your hands in the room, which somebody takes who takes a supplement, any kind of vitamins. A fair number, okay? Because a lot of people do. So we'll see, why. What is the evidence for that over just eating a healthy diet with fruits and vegetables? And so the use of supplement use has been pretty constant over time. When you look at NHANES national surveys from 1990 to 2012, the prevalence has been pretty consistent, but there are demographics where there's higher use. So older adults, women, so here, older adults over the age of 65 have a higher prevalence. Women here in the dark bars compared to men. White race compared to non-white race. And college educated compared to non-college educated, with 50% here being in the red mark. So these are groups where the prevalence of supplement use is even more common. But actually, educated white women are probably the least group at risk for nutritional deficiency, and yet they're the ones that use them the most. And then the concern is, since I'm going to talk about potential harm, most of these things are safe. They may not be effective, but most of them are safe. But there's actually some concern for harm, and often it's concern how many kids are taking supplements. Over a third of kids take a supplement. A lot of times these kids' vitamins, these gummy vitamins, look like candy, and they have food coloring, and they look like candy. And there's been cases of overdose of kids eating bottles of them because they taste like, they're pretty tasty. They taste like candy, And so, but there can be risks, particularly when you overdose on these things. And what is the added gain over encouraging a diet full of fruits and vegetables to get all your nutritional needs? And there's actually 23,000 emergency department visits each year attributed to supplement use. So these things are not all benign, even though you can get them over the counter. And admissions to the ED for supplements have been related for a bunch of symptoms like palpitations, chest pain, tachycardia, choking, dysphagia. Women are more likely than men, but they're also more likely to have be supplement users. So women are the pink and the blue are men. And probably the worst supplements are the weight loss ones because they often contain stimulants in them. But other supplements for other purposes are also have a fairly high frequency of emergency department visits. So, with all these people taking it and actually concerned for harm, there's a huge amount of money being spent on this. Every year Americans spend $21 billion every year on supplements, and it's estimated that there'll be $300 billion US worldwide by 2024. So that's a lot of money. And what is the added gain for all this? Like, would this be better invested in having, healthy, non-processed fruits and vegetables, promotion of physical activity? There's so many other prevention efforts that may have more gain, to spend all this kind of money on. So what if I told you that most supplements don't work despite all of these billions of dollars spent on them, and that real food for most cases is far better than any supplement? My colleague, Eliseo Gilliar at School of Public Health back in 2013 wrote this editorial. It's one of my favorite editorial titles in Annals. He titled it, "Enough is Enough, Stop Wasting Money on Vitamin and Mineral Supplements." And that was 5 years ago, and the prevalence hasn't gone down. And actually, for some, it's going up. So, the message still doesn't seem to be out there. So, there is biological plausibility why people thought that these may help. I'll go through some of the individual supplements. So certainly antioxidants. We know oxidation plays a role in the pathogenesis of atherothrombosis. So LDL, once it's oxidized, it's pro-inflammatory, it's taken up by monocytes and converted into foam cells, and this is one of the precursors for atherosclerotic plaque. So oxidation plays an important role in atherosclerosis, and so in theory antioxidants may have a benefit. But when you give it in the form of a supplement, we haven't seen a benefit, and there's actually been some signal of harm. In secondary prevention, the women's antioxidants cardiovascular study, women either with known cardiovascular disease or risk factors, there was no reduction in vascular events when given vitamin C, vitamin E, and beta-carotene. Although not in this study, after that there was a signal of actually increased, when you pool meta-analyses together, it actually increased risk of cancer, particularly lung cancer with beta-carotene, and with that, so actually harm rather than benefit. And in primary prevention, the Physician's Health Study, again, showed no reduction in vascular events with vitamin C or vitamin E. So people are taking these, but they haven't been shown to reduce events. And so this was a meta-analysis in JACC by Jenkins et al. Just this summer. And I don't expect you to see all these individual trials. There's 21 randomized clinical trials. But the take-home point, if you just look at the confidence intervals, is that there's actually no evidence that antioxidants reduce cardiovascular disease or mortality. And actually, the estimate was on just barely, but it was on the side of harm. And if you actually took out the selenium trials out of here, this was actually strengthened a bit. So actually, it looked like there was more mortality with antioxidants rather than any kind of hint for benefit. So I would recommend not taking those. So folate and B vitamins is another one that had a lot of interest and had biological plausibility, because we know that folate and B12 and B6 are cofactors in the homocysteine metabolism. So homocysteine is thought to be a promoter of atherothrombosis from a number of mechanisms, including endothelial dysfunction and promotion of oxidation of LDL. And if you promote the metabolism or the breakdown of folate, of homocysteine through folate B12, potentially theorized it could reduce cardiovascular risk. But I think importantly to note is in the US, since 1998, cereals and grains are fortified with folic acid. And these are pretty common in the US diet, so the vast majority of people, at least in this country, get enough folate through diet. And so whether there's any added benefit, is more better if you don't actually have a nutritional deficiency. So, in most of the US studies and the earlier meta-analyses, there was sort of a null effect in giving supplements for folic acid. Folate and B vitamins, this is for data from HOPE, so this was secondary prevention vascular disease. Folate and B vitamins did what we thought it should do. It lowered homocysteine levels. But if you look at major cardiovascular outcomes over 5 years, there was no benefit. So some of the earlier meta-analysis, again, showed no benefit. But this was actually in contrast to China, the study in 2015, the China Stroke Primary Prevention Trial. Now, importantly, China does not fortify their foods with folic acid. So this gets back to the concept that maybe if someone has a true nutritional deficiency, there might be a benefit, but not if you have adequate levels. So in this trial, it was all hypertensive patients in China. So China has a large prevalence of hypertension. There's a stroke belt. It's really important in this country. And they randomized participants to enalapril versus enalapril plus folic acid. And there was about a 21% reduction in first stroke, as well as cardiovascular events with the combination. So folate seemed to reduce stroke in China. So in an updated meta-analysis, again, this is the one from the summer in JACC, that if you add this study in, the overall benefit, there was a 20% reduction in stroke with folate, as well as total cardiovascular events driven by stroke. But almost all of this was weighted by the China study. So if you look, these just had a few hundred people, but the China Stroke Prevention Study had over 10,000 people. And so, the big bar here weights it. So the benefit is, so it was a benefit, but it was largely driven by this one study. So still begs the question that in places like the US or places elsewhere, whether there's any gain from folate if you actually get it in through your food. And again, none of these things are completely benign, that there actually has been a signal in randomized clinical trials for increased risk of prostate cancer with folic acid in these RCTs. So, unless we can show that, like in the US, if we get it in our diet, I don't give my patients folic acid for the purposes of stroke prevention. In women of childbearing age, the recommended daily allowance is 400 micrograms a day, and women of childbearing age should probably take 400 to 800 to prevent neural tooth defects. But these doses in older adults for stroke prevention, I'm not currently doing in this country. Now, niacin, another one that was a lot of interest, B3, and again, again, a suggestion of harm, certainly not any benefit, and actually this is that same meta-analysis in the summer. These are CVD, CHD, all the different cardiovascular outcomes. But mortality, trended to harm with niacin, with a 10% increased risk of all-cause mortality using supplemental niacin. So again, not something that we would endorse routinely for prevention. And one thing I don't think a lot of people don't know is the issue with biotin and affecting commonly used amino acids like troponin, which this audience probably orders a fair amount of troponin or has to interpret the troponin call. Biotin is B7. It's a water-soluble B vitamin. But it's being marketed widely in the market to take this for your hair and your nails and your skin and all this stuff. So a lot of patients take this, and we don't ask them about this when they come in and we measure their troponin in the emergency room. Now, they recommend daily RDA for biotin from the diet, and there is biotin in food. It's quite small, and that amount won't affect your assays. But the issue is in supplements have over 650 times the recommended daily allowance. These are huge doses, and they can actually raise your serum biotin level. And why that matters is that many of these commonly used blood tests, these amino acids, rely on a biotin streptavidin binding to capture antibodies. And so this is used in this immunoassay for things like troponin, TSH, a lot of these assays that we order. And if we don't ask patients about this, the supplements can affect their assays, both directions. It actually can have false positives and false negatives. And so it's something that we need to ask patients more about supplement use. And again, since this has never been shown to have cardiovascular benefits, why are people taking this? So omega-3s, again, another, we know that high doses of omega-3s does reduce triglyceride levels, but whether this should be used broadly for primary, secondary prevention, the current data suggests not. This was a meta-analysis from earlier this year in JAMA Cardiology, coronary disease, stroke, so forth, and again, showed no benefit. And the results support that we shouldn't be using omega-3 supplements for the prevention of CVD in patients that were at high risk for it. And again, just like I should have mentioned that you can get biotin in foods like egg yolk, almonds, cauliflower. You can get omega-3s, either fish and seafood have EPA, DHA, but there's plant-based ALA and things like chia seeds, nuts, flax seeds. So you can get a lot of this through your diet. After that JAMA Cardiology meta-analysis, there was another one from the Cochrane database, a systematic review this summer. Lots of data, over 79 trials, and their review was similar to what was said before, that increasing EPA and DHA has little to no effect on cardiovascular health, at least from supplement trials, not from diet. And that earlier studies that suggested a benefit, those studies seem to have a high risk of bias. And if you looked at studies that have low risk of bias, we don't see a benefit. There's some evidence that ALA, might have some benefit. And again, we probably would recommend doing this through plant-based. The fish is a little bit controversial. The AHA recommends fish twice a week, and I certainly think it's better than supplements. The question which remains is whether fish in and of itself is beneficial or whether it's a substitutory beneficial, because if you eat one thing, it's often replacing another thing. So if you're eating fish instead of foods that are high in saturated fats, processed meats, if you're replacing it from something that's far worse for you, then it's likely a benefit, but does it have independent benefit? Even more recently, you may have seen the ASCEND trial last month in New England Journal, looking at over 15,000 patients that had diabetes but no known cardiovascular disease. And they were randomized to 1 gram of fish oil versus placebo, and there was no benefit for, so broadly in primary prevention, even in patients with diabetes who tend to have metabolic abnormalities, there did not seem to be any benefit at this dose of 1 gram for cardiovascular benefit. Now, I will point out, because this is going to be presented at the HA, about, we'll see what reduce it shows before we put the nail in the coffin and say we're done with omega-3s. I mean, I think that be interesting to see what this is. I don't consider this a supplement. I consider this a prescription, and I don't even know what the results are. It's going to be accepted as a late-breaking clinical trial at AHA in November, so we'll find out. But Reducit enrolled patients with established cardiovascular disease. It was a high risk for it, so it was generally a secondary prevention trial, and they were all on a background of statin treatment. And to get in the study, you had to have elevated triglycerides between 100 and 150. So this was people enriched by hypertriglyceridemia. And they're randomized icosapent ethyl 4 grams a day, so again, much higher than was used in ASCEND versus placebo. And what this compound is basically EPA in this ethyl ester form. Cardiovascular events have been collected. They have enough events, so we'll find out whether this shows. And if this is null, then I think we are done with omega-3. But maybe if this is positive, maybe selectively a very high dose in individuals who have hypertriglyceridemia. So we'll wait to see. So moving now to multivitamins, which is what most supplements people take. I worked with June Kim, who is now a junior faculty at University of Alabama, on this meta-analysis. We had, looked over 2 million people were included in this meta-analysis looking at multivitamin use in CVD, and we didn't find any benefit for CVD with multivitamin use, which supports the guidelines that, the guidelines already say that we shouldn't be using multivitamins for the prevention of CVD or cancer, but people do anyway. This was from our paper when we looked at various CVD mortality or stroke mortality. Again, null, that there was no evidence of benefit, maybe no harm, but no evidence of benefit for multivitamin use, despite the fact Americans are spending $21 billion a year on this stuff. So then moving now, is interesting, one of my topics I think is really interesting is vitamin D. So vitamin D may be a little different than everything I've talked about before, because it is actually something your body makes in response to sunlight and acts like a hormone that regulates over 200 genes in your body. So it's a little bit different than a nutritional supplement. It's actually, a hormone that's involved in, calcium, phosphate homeostasis. And we know it's important in the prevention of rickets, osteoporosis, possibly in fractures in people that are particularly at high risk for fractures, maybe not broadly. And there's been a lot of interest about vitamin D in the prevention of many chronic disease state, autoimmune disease, asthma. There's been a lot of interest in this area. So D3 is cholecalciferol. This is what we make endogenously, and D2 is found in plants, ergocalciferol. So because I'm from Hopkins, I just want to point out that vitamin D was discovered at Hopkins. I wasn't there at the time, but Elmer McCullen, he joined Hopkins at the School of Public Health in 1917. He was our first director of what was called the Chemical Hygiene Department at that time. And he paired up with a pediatrician, and they were looking at experimental models of rickets. I like history, so I'll just go back in time for this old paper. So they had already previously shown that cod liver oil can prevent rickets in rats. Because rickets was a big problem back then at the turn of the century. And so initially they thought it was from vitamin A in cod liver oil. But they had this animal model where these poor rats, the rats were only given like these single grain cereals and they wouldn't grow, and they had this poor ricket rat here with this poor bone mineral loss. But they would give back individual nutritional components to see if they can reverse this phenotype. And in 1922, McCollum used cod liver oil that they had radiated to destroy the vitamin A. And they gave the cod liver oil, and it still reversed rickets. And so that they realized that it wasn't vitamin A, it was something else in the cod liver oil, and that led to the discovery of vitamin D. And it was named vitamin D because it was the fourth anti-ricket vitamin in the series. And so that's the history of how vitamin D was found. So to make sure that we're all on the same page, I'm just going to review vitamin D metabolism. Vitamin D, we have vitamin D3 in our skin, and after irradiation by UVB sunlight, our body makes D3, cholecalciferol. We can get cholecalciferol or ergocalciferol from diet. And then it's hydroxylated in the liver to be 25-hydroxy-D. So this is the primary circulating form that you might be ordering on your patients to see if they're sufficient or insufficient state. This has a half-life about 30 days, and so it's a good measure of your body stores, but it's actually not, the active component. The active component is under tight regulation by parathyroid hormone and others, but requires an additional alpha hydroxylation in the kidneys to be 1,25 dihydroxyvitamin D, which is calcitriol. So calcitriol, has a half-life of 12 hours and is very tightly regulated because hypercalcemia is dangerous. You want to keep your serum calcium level in a very narrow range, and so this is very tightly regulated, which is why people can have pretty profound vitamin D deficiency and still have calcitriol in the normal range, because your PTH, until you can no longer make any more PTH, your PTH will, until your kidneys can't make any more calcitriol, we'll try to keep this in the normal range. That's why calcitriol, even though that's the active hormone, is not a good marker of your body stores. But this is the one that binds to the nuclear receptor and has all the effects that we think about with calcium homeostasis and bone health. And maybe, as I'll show you with some of the animal models, important in regulating blood pressure and insulin production. But it's also becoming increasingly recognized that many local tissues in the immune cells and breast cells, colon cells, also have the 1-alpha-hydroxy enzyme and can locally make calcitriol. And while that doesn't contribute to circulating calcitriol, it may have a role in the prevention of autoimmunity. There's been interest in vitamin D with multiple sclerosis, rheumatoid arthritis, and maybe in cancer prevention, and that may be from this paracrine autocrine effect. Now, there is some vitamin D in foods, but it's fairly limited. So, your best bet is salmon, especially fresh salmon. There's 600 to 1,000 IUs of vitamin D3, but otherwise, most people don't eat sardines or cod liver oil in the U.S. diet, and the other foods don't really have it. There is vitamin D fortified in milk and orange juice in this country. It's about 100 IUs for 8 ounces. But consider that in peak summer season, in the summer, if you exposed your arms and your legs to the sun, most people, of course it depends on your skin pigmentation and the time of day, but you can make 3,000 IUs of vitamin D with 15 minutes of sunlight exposure. So that's the equivalent of drinking 30 glasses of milk with like 15 minutes of sun. So really, diet plays a very small role in vitamin D. It's really skin production that's really what's so important. So there's a lot of controversy still a bit about what's adequate for vitamin D. So if you were to read like the Endocrine Society guidelines, they say, well, while 20 is deficient, that, really you need above 30 to be adequate. And this is what tends to, if you order from Quest, or you often see, that it comes back and you have a patient who has a level of 25 and it says they're insufficient, and then they end up getting on supplements. And, maybe we're creating a pandemic of insufficient people by having these arbitrary cut points that are too high than we really need. And so, if you pick this high cut point, there's 1 billion people under this cut point. So the Institute of Medicine, reviewed the evidence, had felt that there really wasn't sufficient evidence to support that we should be targeting everybody above 30. In fact, they said, levels above 16 should meet the daily recommended requirements for health for 50% of the population. But levels above 20 should meet the nutritional needs for 98% of the population. So they said levels above 20 should be adequate for all that you need. And like most things, there isn't a lot of evidence that more is better. In fact, more can be harmful. And so to meet this, they had said in this document that, based on simulation, that most adults need 600 international units of vitamin D a day to get to this level. I don't know if you're above 70, 800 IUs. They set 4,000 IUs as the maximal tolerable limit. And I'm going to get to calcium in a minute, but just to point out, because it's on the slide, that in the same document they said that if you're a man over 50, 1,000 milligrams a day, and if you're a woman over 50, and both men and women over 70 should take 1,200 milligrams of calcium a day, with the upper limit of calcium being 2,000 IUs. So as I mentioned, those were what was put forward, but a lot of people are taking more. And although the NHANES data from the other supplements had showed that supplement use was pretty flat over the past couple of decades, The one supplement that's really taken off is vitamin D. From 1990 to 2012, gone to 5 to 19% of the general U.S. population has been taking vitamin D, increase particularly in women. And there's a small but fair number of people that are about 2% of the general U.S. population are taking more than 4,000 every day, and that's the maximum daily allowance. So a lot of people are taking these really high doses. I think a lot of this is driven by some of the mass amount of publications and talk about vitamin D. I've done a lot of work with vitamin D, so I might have contributed to this, but if you just did like a PubMed search and you look at other vitamins, vitamin C, A, E, citations about that have been pretty flat, thank you, over the past few decades. But look at this exponential rise in PubMed publications so there's a lot of talk about it, and so the media, gets a hold of this, and public get a hold of this, and people start taking all this stuff. So, as I mentioned, I was interested in this. I, did a lot of work in this. I mean, this is one of my first papers on vitamin D more than a decade ago. I was a co-author with a colleague of mine, and we looked at NHANES data, and we showed that individuals with levels less than 20, not so much the higher levels, but levels less than 20, had increased risk of mortality over the subsequent 9 years. And not only, it wasn't a straight inverse, not only was there no gain with higher dose, but it almost looked like U-shaped, where the mortality started going up at the higher ends. So, we adjusted for everything we could in this analysis, but the main question comes back, is this causal, or is this just a marker of poor health? Are people with low vitamin D just people not as in good health, who are not going outside and getting outdoor physical activity and getting sunshine? Or is it that healthier people have higher levels? So is it a marker of just health, or is it actually causally related to disease? If I gave vitamin D to a deficient person, can I actually prevent outcomes? So that was mortality, but there's been a lot of papers also looking at CVD. This is a meta-analysis of 19. These were observational studies. I'm looking at low levels, less than 20, that pretty consistently that if you're deficient, particularly if you're more deficient, there's increased risk of CVD in these observational data. And again, it's pretty flat. So there's no evidence that you should get everybody above 30 or 40 or 50. There's no evidence of benefit. Again, we don't know if it's causal or confounded. And so I did a lot of stuff in Mays and Eric, and we're epi, so we can do all kinds of papers quite easily. So we looked at low vitamin D predicted AFib, and it predicts PAD, and it predicts diabetes, and it predicts incident hypertension, and it predicts heart failure, it predicts stroke. I mean, it's a marker of all these bad things. So it clearly is a good surrogate marker of badness, but the question is it something that we can modify and treat and actually improve outcomes? And there's an interesting racial paradox. So this is one of my papers from Eric looking at incidence. So these are people free of coronary disease, and looked at who developed coronary disease for the next 20 years. And again, we saw in whites that people with levels less than 20 had an increased risk in multivariate analysis of increased risk of coronary disease. But in blacks, it's much more attenuated. It's actually pretty flat. Maybe there's a little excess at these extreme levels, but the risk that low vitamin D confers on coronary disease isn't as strong in blacks. And blacks have much lower levels of vitamin D than whites. They're much more likely to be deficient because the dark skin pigmentation acts as a natural sunscreen, the melanin in the skin, so it decreases skin production of vitamin D. So levels are clearly lower, but that the risk that low levels confer seem to be much weaker in blacks. And we saw this with heart failure and a bunch of outcomes. This was also Eric data looking at incident heart failure. Again, low vitamin D, strong predictor of who goes on to develop heart failure and people who are free of heart failure baseline. But it was all in the whites. Look at low vitamin D in blacks. It didn't predict heart failure in blacks. So there's this paradox where blacks have lower levels of vitamin D and higher PTH. But despite that, their lower levels, they actually have higher bone mineral density, and they're less likely to have fractures compared to whites, despite the fact they have lower levels. So that's what's kind of paradoxical. So maybe 25-hydroxy is not the whole story, and there was interest in free vitamin D, bioavailable vitamin D. And initially it was thought that there might be a difference in vitamin D binding protein, meaning that there would be differences in bioavailable vitamin D, but actually that's been disputed now. If you actually look at a set of older radioimmunoassays look at mass spec. Actually, the binding protein, because vitamin D is largely bound, is similar between whites and blacks. So that itself does not explain the racial paradox, which still remains unexplained. So we're doing work now looking at genetic, what genes are turned on, and trying to figure out, there's something more than just the level in terms of how the body processes vitamin D, why we have this difference. So this is a busy slide, and I'm not going to go through this whole slide. I'm pointing out that there's lots of theoretical biological basis about why vitamin D may be beneficial for cardiovascular disease. Again, it had good biological plausibility. We think vitamin D might regulate the autoimmune system and be anti-inflammatory, anti-fibrotic. I'll show you some animal data. It may reduce the renin-angiotensin system. So there is biological plausibility more than just, that it's all confounded. And some of the animal data kind of supports that this actually may have a biological role of importance. So this is a mouse model of vitamin D deficiency. It's a vitamin D knockout mice. So they don't have the receptors, so they're essentially vitamin D deficient. And they have higher blood pressures compared to wild-type mice. And this phenotype can be reversed if you give them captopril. We know that vitamin D, if you give activated vitamin D, even in normal mice, wild-type mice, calcitriol suppresses renin secretion. So it seems to inhibit the RAAS system, and we think RAAS excess is harmful. So that's one potential mechanism of why having adequate vitamin D might be important for health. And in this experimental model, it looks like maybe adequate vitamin D treatment may prevent heart failure. This is a salt-sensitive rat model that if you give these rats salt, they develop a dilated cardiomyopathy. So this is an M mode, and so this is normal. You see this nice contraction of the left ventricle of the rat, and then with high salt, they develop cavity dilatation and poor contraction. But in that same model, if you give them salt, but also give them paracalcitriol, vitamin D analog, they don't develop heart failure. It blocks this effect. And if you give them calcitriol, they actually had less wall thickening hypertrophy and improved fractional shortening. So it seems like, at least in rats, that vitamin D can prevent heart failure. But the question is whether they can do this in humans. And then vitamin D actually may inhibit or slow the progression of atherosclerosis in animal models. So this is another different type of model. These rats were vitamin D deficient because they overexpressed 24-hydroxylase. This is the enzyme that breaks down calcitriol. So they were vitamin D deficient because they were breaking down all their active vitamin D before they could utilize it. So if you give these rats a high-fat diet, they develop some plaque, but if they were vitamin D deficient and you gave them a high-fat diet, they have tons more atherosclerosis, greater plaque lesion, suggesting that vitamin D, may be important to kind of prevent this development of atherosclerosis. And using human cells, this was an interesting study. They took from patients with diabetes macrophages, and they put them in a media with oxidized LDL. And if you give the macrophages oxidized LDL, they do what we think. They take up lipid, which is the staining here in red, and they become foam cells. But if you add vitamin D to that media with oxidized LDL, there's a little tiny uptake, but you can't even see the red. They don't really take the uptake. So it seems that vitamin D may block this conversion of macrophages into foam cells. So all that's well and good, but so let's give this to patients. Can vitamin D prevent cardiovascular disease? And this is where the data falls off, at least to date. That to date, there has not been any trial that's showing that vitamin D supplements reduce cardiovascular events. Now, many of the older trials CVD was a secondary endpoint. There were, fracture trials and so forth, but it's all been sort of null. The other big limitation is that most of these trials didn't specifically enroll people that were vitamin D deficient. And again, I'm a big believer that if supplementation is going to help anybody, it's going to be people that are actually deficient rather than giving it to a broad population. Now, one of these studies, the VITA study, came out last year. It was in a primary care practice in New Zealand, 5,000 patients. They were randomized to 1,000 IUs of vitamin D once a month, so pretty high dose versus placebo. And while they didn't specifically enroll just vitamin D deficient, a quarter of their patients were vitamin D deficient. But at least at this dose, which again is not quite physiologic, but there was no difference in cardiovascular events over the 3 years. And in their subgroup analysis, when they stratified by baseline levels, they didn't find any heterogeneity of any benefit in the deficient group. Now, in this trial, again, it was null for the major outcome, primary outcome, but I'll point out that, you know, there may be some signs of encouragement in maybe special subgroups, like this is a heart failure study. There was 4,000 patients with heart failure, and they were randomized. This is Vindicate. 1 year, they were taking 4,000 IUs of vitamin D a day versus placebo. So the main outcome was change in 6-minute walk at 1 year, and it was null. So they didn't make their primary outcome. But there was some signs that those randomized to vitamin D had some improvement in their LV dimensions and ejection fractions. But whether this actually translates to meaningful things such as, you know, reduction in symptoms and clinical events remains to be seen about using vitamin D in this purpose. So there are still quite a bit of vitamin D trials ongoing, so maybe the story isn't over yet, and some of them are looking at things like diabetes and blood pressure, and many of them looking at CVD. I think the one that people are probably most interested in is the VITAL trial by Julie Buring and Joanne Manson at Brigham that enrolled over 25,000 men and women over the age of 50 that were free of cardiovascular disease and cancer at baseline. And they were randomized at 2,000 IUs of vitamin D, which is a much higher dose than some prior trials versus placebo. There's the fish oil arm, so maybe we haven't heard the end of fish oil. But they're looking at outcomes. Now, the trial has been completed, and they're just doing follow-up, and I think it's anticipated to be maybe published early next year. I think it's going to be null. I think it's going to be null because they didn't specifically enroll a vitamin D deficient population. Now, they did measure blood, and a fraction of these 6,000 individuals had blood. So they're going to do some post-hoc analysis that they've stated a priori that they're going to stratify by baseline levels. So that might be useful to see if there's a benefit in people that were truly deficient. You know, we'll see. So we anxiously await, but I have a feeling it's going to be null. The other question, so I've been talking about cardiovascular disease, but people will take vitamin D for other health things, and there's been a lot of question about falls in the elderly. The American Geriatric Society recommends vitamin D supplementation, but the fall data is also quite mixed. While some older data suggested benefit, there's been actually 3 more recent trials that actually suggested increased falls, but they were, like one of them gave 500,000 IUs of vitamin D once a year, which is, you know, not a very physiologic dose, a huge amount all at once, and there was higher falls. So with this kind of mixed data, actually the NIA, the National Institute of Aging, had this RFA for this grant, and my colleague Larry Apple was awarded funding for this trial, which we're doing at Hopkins, and I'm one of the investigators for one of the sites, one of the clinic sites, when I got to chair the design committee and work with Larry. But this is what we're trying to answer in the STURDY trial. Falls is the main outcome, and we're enrolling older adults. We're randomizing them to 4 doses of vitamin D. The control is only 200. But everybody has to be vitamin D deficient to get in. So we made that a requirement, which is why there's no placebo. We have a 200 in there just because everybody's deficient. So we give them a little bit, but from 200 to 4,000 spans the dose. And so we'll see whether vitamin D, even if it's null, I think it will help guide future guidelines to be giving vitamin D to older adults. So that's ongoing. We're still recruiting for that. And then one of my grant funding in Eric was looking at vitamin D in brain health. Initially, I was a little bit even more enthusiastic about vitamin D before all these null studies came back. And so I measured vitamin D, and we looked at 20 years of cognitive data in Eric, and it was all null. So that there was no evidence that vitamin D levels, at least in midlife, had any impact on later life cognition. But even though it's, you know, you have this grant and the results are null, I mean, I think it's important to still publish null results because I'm hoping it might dampen the widespread enthusiasm of using vitamin D for brain health and cardiovascular health. So another area of interest of mine is calcium, which is closely related to vitamin D. And we know that calcium plays an important role, you know, in muscle contraction, clotting, nerve impulse transmission. But 99% of the calcium in our body is tied up in bones. Only 1% is really circulatory, but bone serves as a reservoir. So calcium supplements is also incredibly common, used by 40% of the US population, $1 billion every year just on calcium. And, you know, what is the data? Is it worth this money for so many people taking this? I mean, again, I can't get my patients to take statins and things, but they take all this stuff. So unlike vitamin D, you actually can get enough calcium from your diet if you try. So there's actually a lot of foods that have calcium in them. So obviously dairy has quite a bit of calcium, but if you're vegan or lactose intolerant, there's actually quite a bit of plant source. There's, you know, non-dairy plant-based milks, but also almonds and broccoli and chia seeds and figs and kale and beans and the stuff our patients should be eating anyway. They can get this without eating, you know, ice cream every day. They can get calcium through healthy vegetable sources, leafy green vegetables. So I definitely try to get my patients to take as much of their calcium through diet. Now, everybody says, I need calcium for my bones, I got to protect my bones, and I got to take my supplements for my bones. Well, what is the data for calcium and fracture supplements? It's actually kind of pretty weak. You know, there's some evidence that in the healthy ambulatory population, so there was some older data in the nursing home, but in those patients, they also had severe vitamin D deficiency. But in ambulatory population and community, the data is actually pretty weak for calcium reducing fractures. And the largest trial, the Women's Health Initiative, you know, calcium plus vitamin D, you know, over 7 years did not reduce hip fracture. And you look at the 4 clinical trials at lowest risk for bias, there's no reduction in hip and fracture. And some of the older studies that showed benefit actually had more bias. So the data is not that strong, despite the fact that everyone's taking this. There is, you know, some evidence that, you know, if you have very low dietary calcium, that increasing it, you know, has a 1% increase in bone mineral density. But there's no evidence that beyond that, that higher intake does not linearly increase your bone density, only if you correct, you know, severe deficiency of your dietary calcium. Furthermore, there's been this signal for harm in some of these studies. This is Dr. Boland and Reed from New Zealand. They first brought this to light when in their 2008 study, the Auckland calcium study. It was supposed to be looking at fractures and bone health. It was a randomized trial of calcium placebo, and then they pointed out there was more vascular events in the calcium arm. And since then, they've been sort of writing a lot about the concern for this. And there's this signal for increased myocardial infarction in some but not all trials. Like there wasn't if you look at overall Women's Health Initiative, but if you looked in subgroups of the non-obese or people not taking personal supplements, you saw the harm there. And we see this in observational data, in the EPIC Heidelberg observational data, that individuals who took calcium supplements had a 2-fold increased risk of myocardial infarction. Now it's observational data, so that comes with all the limitations of that. But you know, we don't see this signal with dietary calcium, that actually dietary calcium had a lower risk of myocardial infarction. So it just seems to be with supplements. And this was my own paper where I looked in the MESA study looking at incident coronary artery calcium by CT among people who had a CAC score of 0, and showed in multivariate analysis, and again we adjusted for everything including calorie intake, that the highest quintile of dietary calcium was associated with a decreased or lower risk of incident CAC, but that calcium supplements was a 22% increased risk of incident CAC independent of everything else. Furthermore, there is lots of other evidence that calcium supplements are not benign. We know that the calcium supplements are binding, that they cause constipation in a lot of patients. And in the Women's Health Study, even though this was null, that it didn't reduce fractures, didn't reduce CVD, you know, there was a 17% increased risk in kidney stones in the Women's Health Initiative. And then there was a clinical trial that just came out this year in Gut, which is a BMJ journal. And they were looking at people taking calcium alone, calcium plus vitamin D alone, a randomized clinical trial looking at progression of colon polyps on serial colonoscopies. They actually went into this trial proposing a benefit, and what they saw was actually a delayed increased risk, a higher risk of colon polyps in the calcium arm, whether it was calcium or vitamin D. And I think that's because then it was kind of late in the end of the trial. So I think it has to do with the binding effect. Since calcium slows your GI motility, that's probably not a good thing. We know things like high fiber that moves GI motility is beneficial for colon polyps. Furthermore, in these clinical trials, high calcium reduces, calcium supplements associated with hypercalcemia, and 9% of individuals, and a third can get hypercalciuria. So why might diet be good but supplements be bad? I think it's a bolus effect. If you take a big amount of calcium all at once, 1,200 milligrams, it transiently increases your blood calcium levels, your serum calcium levels. And even though it comes back to normal, if you were to see them in clinic and measure that, most people on supplements won't have elevated serum calcium. But this transient rise may be enough to trigger your clotting time because calcium is involved in the coagulation cascade. So it may be that this transient elevation in serum calcium leads to blood clotting or vascular events. Now in this meta-analysis, it was null, looking at all these different outcomes for calcium supplements versus placebo from these various randomized clinical trials. But look at all the point estimates. It might not be statistically significant, but they're all on the wrong side favoring harm. And so to wrap up, I really try to encourage my patients to get as much as they need of calcium from diet, and not, if they do need it, if they can't get it through diet, just the smallest amount as possible. And that the U.S. Preventative Task Force has recommended insufficient evidence that in the general population we shouldn't be using vitamin D and calcium. So I'll end there. I just want to point out that there's this nonsense out there, vapable vitamins and patch vitamins and intravenous vitamins, and just do this. Eat. Vast majority of people can get all the nutritional they need through a healthy diet. So I'm happy to, thank you for having me. I'm happy to take some questions.
Thank you, Erin, for really fascinating. I don't know there was so much data on supplements and vitamins and everything else, and it really was very informative and so informative. Questions?
Thank you so much. That was just fabulous. One practical question. As you know, the PPIs have been linked to higher risk of cardiovascular disease. And in the process of getting our patients off PPIs, which is very addictive for the mucosa of the stomach, I can testify for myself, it took me 6 months to get off omeprazole. We frequently tell the patients, take Tums and go through the process, which I did. Question is, how much calcium does somebody get when they're taking 3 or 4 Tums a day? Is that a significant amount, or is...
Yeah, so I don't really recommend Tums so much. You have to look, so it really varies by, even if it says take 1 pill, 2 pills a day, there's a huge amount of variation in calcium in pills, so you really have to read the labels and look for elemental calcium. So a small amount, can contribute towards the daily recommended allowance, but using the smallest amount as possible. But if patients do need some, and this is for a general population, so there may be individuals who are high risk for fractures that we do recommend calcium. So in general, I recommend calcium citrate rather than calcium carbonate. So that wouldn't be Tums. The calcium citrate doesn't seem to be associated with kidney stones like the calcium carbonate is. So I actually really don't recommend Tums. There's other antacids, Zantac, and things like that. But
my question, I guess, is how dangerous it is for somebody to go through 6 months of using a lot of Tums trying to get off.
So I would look at how much calcium is in the pill, because everyone's different in terms of that, and I would try to, not exceed 500 milligrams a day, to use the lowest amount as possible in any kind of supplement, whether it be Tums or something, and try to get the rest through diet. But I would be concerned if there's a lot of how many pills a day, how much is in there. So I don't recall in Tums off the top of my head, but I would read the label. But
yeah, thank you for the great overview. I'm a heart failure specialist,
yes.
And in this focus of heart failure, you showed a lot of negative evidence in general for supplements and the public perception. I was intrigued. We started a patient support group. My first patient support group, I was expecting them to ask me questions about science, technology. All their questions were, what supplements can we take? What diet changes can we make? But surprisingly, there's this perception in the culture that natural supplements is natural, even though they're made by companies.
Right.
And medicines that we prescribe is bad.
Right.
So do we have enough to actually have an anti-supplement public campaign?
Right. I'd point out tobacco is natural. Arsenic is natural. So, I mean, tobacco is a plant, so just because, food and vegetables are natural. So I try to point out that just because something's over the counter doesn't make it safe. Like, look at all I didn't talk about this today, but all the aspirin. So you can get aspirin over the counter, and people think it's so much more safer because they get over the counter, but they don't want to take their statin, yet the therapeutic window and potential for harm. So, I just try to, it's a difficult situation. You have to, talk to patients and see where they're coming from. And often I bargain with them about which ones that they take and things like that. But it's people take that stuff all the time without evidence. And just because it's over the counter or not regulated doesn't mean it's safe. But I try to point out, this is natural. So, if they want to be natural, go as minimally processed as possible. Not something, I describe how it's made in the lab, and once you take out the compounds out of its natural sources, it doesn't have the same benefit as when it's in food and with other macronutrients and micronutrients. And some people buy it, and some people will never pull the supplements out of their hands, no matter what you say. So.
Yeah, a very nice presentation. I say this not as a cardiologist, but endocrinologist.
Oh, okay. Yes.
I'm not a bone and mineral person, although we have one.
Did you dispute now?
That's right. But my only question is...
A friendly endocrinologist.
My only question, at your STURDY trial, are you looking for consequences of the fall? Not just whether they're falling or not, but what's happening, especially to long bones. Are they fracturing their wrists or their hips when they fall?
Yeah, so we're collecting fall outcomes. So we're not doing bone mineral density, but we collect fall outcomes, and then we're finding injurious falls, the type of falls that, falls with hospitalization. So, we're categorizing the severity fall. So those are all secondary outcomes. We also have enormous amount of, we're doing SPPV and gait speed, and they're wearing accelerometers. So we're trying to figure out if they're falling, is it because they're moving more now that they're getting vitamin D? Maybe they weren't falling because they weren't moving more, so we're doing activity. So there's a lot of secondary outcomes. So we're capturing types of falls, although we're not actually measuring bone mineral density in this study. Or fracture. We're capturing fractures. If a fracture, that's a reportable event and adverse outcome, and we're tracking that. So that'll be secondary analyses.
Great. This was outstanding. Thank you very much. So I've got a little digression. The question, what is now kind of the current state-of-the-art recommendation with regard to hormone replacement? So estrogen for women, testosterone for men.
Yeah, so I mean, right now we certainly don't recommend hormone therapy for the sole purposes of cardiovascular disease prevention in women. Subgroup analyses from WHI and others have suggested that there may not be excess harm in the perimenopausal, the younger women. So while I don't use it for CVD prevention, many women have disabling hot flash symptoms that are quite devastating. And so it does seem that for a short term, if they're not at high vascular risk, that it's relatively safe in the 50 to 55-year-old woman. But usually I pull women, off of it by the time they get, over the age of 60 or get closer to the age of Women's Health Initiative, and use other therapies to handle vasomotor symptoms. And then testosterone therapy in men, is again a sort of a little bit of controversial area. I'm certainly not using for CVD prevention, but people take it for other indications and trying to find safety. It does seem in women, though, our data suggests that testosterone may be harmful. We've shown excess risk of cardiovascular disease events with women with higher testosterone levels have more CVD. But in men, we didn't really see that excess risk.
Carla Krollmeyer. I see a lot of women, so
Yes.
I get a lot of vitamin questions. So there is this multi-million-dollar business of just taking whole plant-based foods and compressing them into multivitamins. So it literally is taking that and putting it in a little pill. So I get that question all the time. Is that healthier than the other supplements? And is there any sort of data that is okay to take because it's whole food?
There's no data. I would ask, why don't they just eat whole food? So I think the whole food plant-based diet, so there's this whole food plant-based diet movement, which I actually think is pretty good because it's a lot of the principles that fit with the American Heart Association and things like that. So I strongly encourage individuals that want to manage lifestyle through healthier diet, but just to eat whole food plant-based diet. But once you start putting something in a lab and trying to process it into a pill, A lot of times things are destroyed when they're processed, and they have the shelf life. It's just not the same as when you can go as minimally processed as possible.
Erin, I have two questions for you. Do you measure vitamin D on your patients, at least maybe one time? You know, you have patients, and particularly young, is now from the dermatologist trying to basically protect their skin, and people in the young generation is much less outdoor than indoor with all the computing and everything else. Do we measure vitamin D? And I know the caution certainly of supplementation, certainly above 20. So do you measure that on your patients? One, and two, I'm just listening to you and see each one of their specialties, meaning all these trials, focuses maybe on one area, like what is it in cardiovascular disease? And patients, most of the time, don't think about prevention for cardiovascular disease. They think about their brain, and Alzheimer's is obviously very, very big, their cognition, and the others about falls, osteoporosis. So the question to you are, some of these trials looking at the total body effect, because there are going to be some positives, some negatives, and ultimately we say, well, maybe it's not going to, maybe it's null for the heart and cardiovascular system, but maybe it's beneficial for this other system, because patients may emphasize one area of the body or the other, but ultimately we have to take care of all of them.
Yeah. So, I do think there's subgroups that might benefit from vitamin D deficiency, particularly your severe deficiently. And by severe, I'm talking about levels less than 12. So once your levels get below 12, you actually can get, bone demineralization. And those are actually a group I think actually needs vitamin D to correct. So I don't think everyone needs to be above 30 or what a lot of this stuff that these labs all kind of create. But people really who have levels less than 12 or potentially who have had fractures or high-risk fractures may benefit. So I don't measure vitamin D in everybody. In people who are particularly high risks, such as those with darker skin pigmentation, older age, who've had like gastric bypass or some reason why they might not absorb fat-soluble vitamins or some other reason to concern, I will measure it, and certainly if it's less than 15 or less than 12, I do supplement to kind of correct that. But there's no data that supplements beyond that point, reduce fracture. And then in terms of the trial, so the Institute of Medicine, when they made their recommendation for having levels above 20 for 98% of the population and those recommended daily allowances, that was based on overall health. That wasn't based just on fractures, and it wasn't based on CVD. It was overall health, and that was their threshold. So most of these trials, have a primary endpoint, but they are looking at other things. So VITAL has a number of ancillary studies. So VITAL's main outcomes are CVD and cancer, but the VITAL trial also has a lung ancillary, they have a cognitive ancillary. So there's things embedded in to try to get at those questions.
Very good.
Mm-hmm.
Yeah, first of all, again, thank you for a great presentation. For many years, all carotid endarterectomy specimens here were taken to the lab, Christy Ballantyne's lab with Joe Morrison, and they looked at bone production, because though you talked about bones, we're interested in the bones and the blood vessels. And there's heavy calcification in almost all the patients that we see. And when you look at it, they're osteoblasts, they're osteoclasts, actually inside the walls of the blood vessels and the calcification. And so, although we've talked about femurs and femur fractures, for example, what do you know about vitamin D and vascular calcification? It's a huge problem because it makes the blood vessels stiff. And you got the same kind of turnover is actually taking place in the walls of these blood vessels. And any insight into whether there's too much vitamin D, too little, whether we can manipulate vascular calcification?
Yeah, so it's a good question. And observational data, we looked at this in MESA, that actually low vitamin D actually had increased risk for vascular calcification. Conversely, there was inversation, so higher vitamin D levels had lower vascular calcification. But I don't think there's a good trial that kind of shows that giving vitamin D can in humans, ameliorate or prevent atherosclerosis or calcified atherosclerosis, or looking at calcified plaque. I think it's how it's quite different. I think it depends also on how much calcium that you're taking in and those things, but we don't have any trial data, just observational data. But in observational data, if you have higher levels of vitamin D, you actually had less vascular calcification. We showed that in MESA.
Well, let's thank Dr. Michos for an amazing, and thank you for coming. Thank you.